phacoemulsification procedure. First step is eye marking and timeout. So marking pins or stickers are used. Patient name is checked. Patient date of birth is checked. Procedure is explained. The operative eye is checked, and type and power of the intraocular lens is checked. So these are the necessary points. Preparation: topical anesthetic is followed by povidone iodine 5% or chlorhexidine. It is instilled into the conjunctival sac. Then the eyelids are cleaned after 3 minutes. The eyelash, it is ensured that it is also applied to the eyelashes. So the antiseptic should be left for a minimum of 3 minutes. Then careful draping is performed, excluding the lashes and lid margins from the surgical field, and a speculum is inserted. These are the eyelid specula. This is the Lieberman speculum. This is open loop speculum and closed loop speculum. The next step is paracentesis. One or two paracentesis incisions are side port. So a side port incision is made around 60 degree to the left in right-handed surgeons, and 60 degree of the main incision. Some surgeons prefer two side ports approximately 180 degree apart. This is the side port has many functions like insertion of a second instrument, introduction of intracameral additives, placement of iris hooks. For paracentesis, 15 degree blade or MUR blade, microvitreoretinal blade is used, and it is inserted parallel to the iris plane. If the side port is wide, this allows excessive fluid to escape. If it is too narrow and too long, this can hinder complete insertion of the second instrument. And if it is too short, this can prevent self-sealing. Then the viscoelastic is inserted. So viscoelastic is injected into the AC. Now the clear corneal incision. It is the main incision, 2.2 to 3.2 millimeter wide. So globe stabilization is necessary, and it should be, the clear corneal incision should be stable, and it should be watertight incision. A beveled trapezoidal diamond blade is used, one motion and in one plane. Another is, so there are two techniques for clear corneal incision. One is beveled self-sealing biplanar incision anterior to the vascular arcade. Here you can see anterior to the vascular arcade, and it is biplanar, one plane, and then it is injected in another plane. Initially horizontal to the iris and then vertical. Multiplanar, initially vertical, then horizontal, then vertical. 0.3 mm deep groove. And there is near clear approach, in which the incision begins within the vascular arcade. It has reduced incidence of induced astigmatism, and there is slight bleeding. And there is scleral tunnel incision, which you can see here, which starts from the sclera. It has the advantage, it reduces the incidence of both early and late surgically induced astigmatism. It is more controlled, and it is used for conversion to ECCE. The initial groove is 1/3 to 1/2 of the scleral depth. Then 2 to 3 mm posterior to the limbus it is started. The tunnel is traditionally dissected past the vascular arcade. A short plane is made by changing the angle of the blade before entering the anterior chamber. Then continuous curvilinear capsular axis is performed by cystotome of bent hypodermic needle or capsular forceps. Another option is cane opener capsulotomy, in which cuts are given here. Continuous small cuts are given. Next step is hydrodissection, but before this step there is a tip for the capsular axis. If trypan blue is used, it effectively stains the anterior capsule and facilitates accurate capsular axis in a patient with a poor red reflex secondary to a dense cataract. Then there is hydrodissection. It is performed to separate the nucleus and cortex from the capsule so that the nucleus can be manipulated. A blunt cannula is inserted just beneath the edge of the capsular axis. Here you can see. And fluid is injected gently under the capsule. Hydrodissection wave should be seen provided there is adequate red reflex. Then hydrodelineation. It separates the harder endonucleus from the softer epinucleus. There is a golden ring sign. Injection of fluid into the body of the nucleus results in the separation of epinuclear shell from the central nuclear mass. There is a golden ring sign. It is seen during hydrodelineation step. Then nucleus rotation. Difficulty in rotation may suggest inadequate hydrodissection or loose zonular fibers or posterior capsule rupture. Then the nucleus is removed by two techniques. So one is divide and conquer, and another is phaco chop. And this is chopping technique. The horizontal phaco chop technique and stop and chop. Phaco fracture divide and conquer technique. It is a two-handed technique. Divide and conquer nucleofractus. It is used for all but very soft cataracts. Continuous ultrasound is necessary. Initially, a deep central linear groove is sculpted, or the trough 1 to 1/2 times the width of the phaco tip. This is the phaco tip. What are the signs of adequate groove depth? Smoothing of the striations, brightening of the red reflex, central depth of 2 to 3 phaco tip diameters. Separate the nucleus into two pieces, nuclear cracking, or rotate the nucleus 90 degree and sculpt a perpendicular groove. Nuclear quadrant is pulled toward the center of the capsular bag and emulsified. So in divide and conquer, here you can see two perpendicular grooves are created. This is known as sculpting. Then this is the phaco tip and this is the second instrument. They are engaged in opposite walls of the groove. And the nucleus cracked into quadrants. By applying force in the opposite direction, Each of the quadrant is then emulsified and aspirated in turn. Then the phaco chop has the advantage of slightly greater speed and lower total phaco energy requirement, but it takes longer to learn. In horizontal chopping, a blunt tip chopper is placed horizontally underneath the capsule and rotated vertically as the equator is reached. Vertical chopping is performed with a pointed tip chopper that does not need to pass beyond the capsular axis. The nucleus is separated into several pieces for emulsification. Stop and chop is a combination technique in which sculpting a central groove and then cracking the nucleus into two pieces. The resulting heminuclei are then chopped into smaller pieces. This is vertical chopping technique in case of loose zonular support. So in horizontal chopping, a blunt tip chopper is placed horizontally underneath the capsule. And vertical chopping is performed with a pointed tip chopper. That does not need to pass beyond the capsular axis. Sculpt setting and the chop setting. Sculpt setting, the central nucleus is debulked. Shaving maneuver ends scaphoid shape of the posterior lens. Chop setting, fully occluded phaco tip and second instrument is used. For sculpting low vacuum limit or chopping high vacuum limit. For sculpting low aspiration flow rate or chopping low to moderate. For sculpting, the ultrasound mode is continuous mode or pulse mode. And for chopping, burst mode. Location of emulsification. Posterior chamber. In the posterior chamber, there is reduced risk of corneal endothelial trauma and the ability to minimize the size of capsular axis opening, which is helpful with a suboptimal pupil dilation, but the disadvantage is increased risk of complications. Emulsification can be done at iris plane in patients who have compromised capsular or zonular integrity. With small pupils, this technique permits good visualization and enables safe emulsification. The disadvantage of working at the iris plane include difficulty prolapsing the nucleus and risk of damage to the corneal endothelium. In the anterior chamber, prolapsing the nucleus through the capsular axis during hydrodissection. It requires a medium to large capsular axis and a relatively soft nucleus. It reduces the stress on the zonular fibers, greater chance of aspirating the iris, damaging the corneal endothelium. It is useful in situations such as the presence of posterior capsule rupture. So OVD is used to protect endothelium and minimize the phaco energy. Irrigation and aspiration. A plate of soft epinucleus or transitional cortex may rest on the posterior capsule. Use the phaco needle to accomplish irrigation aspiration without ultrasound. Our Simcoe cannula is used at reduced vacuum and flow settings. OVD for cortex resistance. Polish the posterior anterior capsule surface to remove residual lens epithelial cells. So, insertion of the intraocular lens. Foldable single piece IOLs, preloaded IOL injector cartridge. So there are preloaded available in the injector cartridge. And polymethylene methacrylate IOLs, they are not foldable. These are modern foldable single piece posterior chamber IOLs. These are foldable 3-piece posterior chamber IOL, capsular bagel IOL or ciliary sulcus using an injector. Posterior capsule rupture, sufficient anterior capsule support, So 3-piece PC oil in the ciliary circus is used in this case. If there is PC rupture and sufficient anterior capsule support. Incomplete lack of capsular support, scleral or iris fixated posterior chamber IOL are used. Polypropylene sutures are used for ACIOL. 1 mm plus the horizontal diameter of the limbus. Pupil is generally constructed pharmacologically. Uterus is removed from the anterior chamber. Peripheral iodectomy is done and OED is placed. This is Kilman style open loop anterior chamber IOL with flexible 4-point fixation. This is implanted toric IOL showing diametrically opposite sets of 3 dots marking the lens axis. After IOL insertion, remove the OED, IA tip behind the optic or pushing the optic posteriorly. Balance R solution is used. Hydrosealing is done. 10-0 nylon suture is used to seal this main incision. In some cases, prophylactic measures are also taken.